everyone, welcome back to the Orthopedic Tutor channel. Today we are going to focus our discussion on the subacromial impingement syndrome. As you've probably seen in my last video, the subcoracoid impingement, I've explained that the impingement condition is actually a continuum of disease which starts from impingement going to calcific tendinosis if there is a degenerative causes, and it could also lead to rotator cuff tear and ends with rotator cuff arthropathy. Well, today's discussion will focus on the subacromial impingement syndrome. Now, basically this condition, as in any impingement, is caused by narrowing of the space beneath the acromion. So epidemiologically, this condition may be associated with an abnormality in the anatomy. There will be a hook-shaped acromion. There could also be an os acromial, which is the failure of fusion between these three centers of ossification. You could see here that the ossification center of the acromion can divide it into the preacromion, this one here, which is the tip of the acromion, and the second part would be the mesoacromion, this one here, which is the middle part, and also the metaacromion at the base of the acromion. So failure of this fusion will cause the formation of os acromial, and is also associated with the conditions of impingement. Now, other causes that are also similar to the causes of subcoracoid impingement is the posterior capsular contracture, and sometimes disorders in the motion of the scapula may also predispose your shoulder to have this kind of condition. Now, epidemiologically, this is a common condition found in around 40 to 60% of all shoulder disorders, and is frequently the common cause of pain. Now, in some literature, you may find that this impingement be included into the first stage of a full-blown rotator cuff disease. Impingement and bursitis will lead to the formation of partial or full thickness tear of the rotator cuff, which in turn will lead to the formation of a massive rotator cuff tear and ends up with a rotator cuff arthropathy, which is an end-stage condition and is characterized by changes in the glenohumeral joints. Now, the impingement itself could come from extrinsic or intrinsic degeneration. Now, the extrinsic compression may come from the acromion. It may come from the coracoacromial ligaments, which crosses from the coracoid and acromion, and it may also cause by the abnormalities in the acromioclavicular joint. Intrinsic degeneration is frequently happening in the supraspinatus, and the attrition of this tendon may lead to inability of our body to balance our humeral head on the glenoid, and further on it will lead on to the superior migration of the humeral head, and it will later on impinge on the subacromial space. Remember this because later on in the next video regarding the rotator cuff tear, you will see that one of the findings of rotator cuff tear is that the humerus may be superiorly migrated. There could also be evidence of intrinsic degeneration of the supraspinatus with tendinopathy characterized by disorganized collagen fibers. Now, after you have learned about these basics, you need to know how to raise the diagnosis of this condition, because patients generally only come with a single complaint of pain. So how do you know that this is caused by a subacromial condition? Then you need to know that the pain is usually considered insidious in onset, and it usually occurs at night, and it may also worsen on an overhead activity, because as you raise your arm overhead to reach for something perhaps, then you actually impinge, you decrease the area under the acromion, and that may induce more pain. So the physical findings, you usually need to do tests that may induce pain, or in other words, you need to do tests that reduce the space available under the acromion. Then that is called the impingement test. And most of these tests do motions that decrease those space that I've been talking about. So such as the NIA. NIA has two types of tests that could be done. The first is called the impingement sign, which is termed positive if during the passive forward flexion above 90 degree the pain is induced over at the shoulder region. Now the impingement test is actually a continuum of the impingement sign. After the pain is elicited, usually you will receive an injection by your doctor, which is placed under the acromion or subacromial injection, and suddenly your pain is gone and you are able to continue on with the passive forward flexion above 90 degree. Now the next test that is commonly done, and this is one of my favorites too, this is called the Hawkins test, and you could do it simply by internally rotating and passive forward flexion to 90 degrees, which will induce pain. The other tests include the Job test, which is done by resisted pronation and forward flexion to 90 degree, and also the internal impingement test, which is deemed positive when there is pain with abduction and external rotation of the shoulder. Now once again, if you want to learn more about these physical exams, it's good if you could log into the Physio Tutor channels. They give marvelous examples of how to perform these specific tests. The next point of discussion for today's video would include the additional examination. As you know that there is a narrowing of a space, and you can actually picture that from the radiograph by measuring several parameters that could be found. The first would be measured from the true AP projection of the shoulder. You could measure the acromiohumeral interval, and it should be at least 7 to 14 millimeter. This is the space, and this is how you take a true AP view. With 45 laterally placed beam, the patient can be sitting, standing, or lying down, and you measure this space here under the acromion and above the humerus. Now this space should be at least 7 to 14 millimeter. And during other specific views, such as this 30-degree caudal tilt view, you could visualize evidence of spurring under the acromion, and other views may include the supraspinatus outlet view taken like this, with the beam from the posterior to anterior at an angle of around 40 degree, and the beam is angled at around 10-degree caudal tilt. And there you could visualize the shape of your acromion. Either it is a flat shape, a curved shape, a hooked acromion, because the hooked acromion has the highest incidence of relation to the subacromial impingement. Now the findings that needs to be sought out for this condition includes proximal migration of the humerus, which is caused by intrinsic changes at the supraspinatus tendon, leading to inability of this tendon to stabilize the humerus to the glenoid, and it shall migrate superiorly. Next would be osteophytes, because osteophytes are signs of degeneration. You could also see calcification of coracoacromial ligament as one of the causes of impingement. There could also be cystic changes of the greatest tuberosity. Other findings include the type 3 acromion or the hooked acromion. You could also find os acromial. Now all of these findings may point out that the patient has an impingement syndrome, but other methods of imaging could also be useful, such as a CT arthrography, the ultrasound to evaluate the quality of the tendons, or also MRI to further seek out for any rotator cuff pathology or any bursitis at the subacromial or subdeltoid region. Now, after you have known how to raise the diagnosis, next comes the question, how will you manage a condition? This is considered an early condition because this is still the early stage of a rotator cuff pathology. So non-operative treatment is the mainstay of treatment with various simple modalities such as physical therapy to strengthen all the rotator cuff muscles, NSAIDs, and also injections at the subacromial space. While the indications for operative treatment may be slightly different because you need to try for at least 4 to 6 months of conservative treatment before you move on to operative treatment. Now the techniques are several, but there are several commonly employed techniques for this kind of condition, which include subacromial decompression and acromioplasty. And that acromioplasty is specifically directed to reshape the acromion that is causing the impingement, especially the one that has a hooked type of anatomy. The next would be the treatment of the os acromial itself. You could try to fuse the os acromial with bone graft and allow it to be healed. Now for chronic tear, usually you need to debride and preserve the coracoacromial arch because this is an important part of the shoulder complex and which then prevents superior head migration. For acute tearing, you could do acromial smoothing and bursectomy to relieve the pain and also to prevent further impingement. Well, considering the management, you need to handle the post-management phase, which could once again be divided into 3 phases. The early phase includes the first 2 to 3 weeks after the surgery, where emphasis is placed on measures to control the normal inflammation and pain that occur post-surgically, and you need to protect the soft tissue healing and minimize the effects of immobilization and activity restriction. The next phase would go on for around 3 to 6 weeks after the surgery, where your emphasis is on muscle strengthening and you need to continue your work on rotator cuff and scapular stabilizer strengthening. And the final phase of the rehab should be continuous and last for at least 3 months, and the emphasis is based on the kinesthesia and also the joint position sense, basically building your proprioception and making it a good one so that you do not injure your shoulder in the future. Now, complications may arise because sometimes deltoid dysfunction may occur due to the failed repair of the deltoid during open acromioplasty, or you may also do an excessive acromionectomy during arthroscopy, which causes this dysfunction. The other thing that may occur is anterosuperior escape of the humerus. This anterosuperior escape usually occurs if you perform the release of the coracoacromial ligament. This is an important ligament to preserve, but if you accidentally release them, then the humerus head has a chance to escape there. Okay, and the last point of discussion would be regarding the prognosis of this condition, which is poor if compensated with workers' compensation claims. You will frequently find this statement in exams because there are certain conditions that have poor prognosis when related with a workers' compensation claims. Okay, that would be all for today's discussion. If you like to hear more videos regarding orthopedic, you please subscribe to the Orthopedic Tutor. Don't forget to log into the other videos, that is the calcific tendinosis, rotator cuff tear, and also the rotator cuff arthropathy, which is associated with this condition. Thank you.